Hello everyone. This video is aimed at giving a brief overview of the Physiotherapy Rehabilitation Protocol following total knee arthroplasty surgery or TKR. So what is TKR? It is a surgical procedure which is performed for advanced arthritis of the knee, which was formerly performed for older patients greater than 70 years with advanced osteoarthritis. However, the proportion of younger patients undergoing TKR has risen by threefold. The primary goals of TKR are to relieve pain, improve physical function, and quality of life. So what are the indications for TKR? First, severe joint pain with weight bearing, extensive destruction of articular cartilage cause of secondary arthritis, marked deformity, gross instability, failure of non-operative management of previous surgical procedure. So what are the types of TKR? Based on the compartments replaced, we have unicompartmental, bicompartmental, and tricompartmental. Based on the implant design, or that is degree of constraint, we have unconstrained, semi-constrained, and fully constrained. Semi-constrained, because of its advantages, is widely used, and fully constrained is rarely used. Next classification is whether the implant is fixed bearing or mobile bearing, whether it is a cruciate retaining or cruciate excising implant. Based on the surgical procedure, we have traditional or minimally invasive, quadriceps splitting or sparing approach. And based on implant fixation, we have three types, that is cemented, uncemented, and hybrid. Thus, knowing the type of TKR or the implant can widely influence the rehabilitation program, and thus it is really important to know these classifications. Thus, the rehabilitation phases include three phases: the maximum protection phase, the moderate protection phase, and the minimum protection phase. The maximum protection phase, also known as the first phase, lasts approximately for 1 month, and goals of this phase are to control postoperative swelling, minimize pain, bring in range of motion up to 90 degrees, increase the strength of quadriceps to at least 3/5 or 4/5 on MMT scale, make the patient ambulate with his or without assistive device, and establish a particular home exercise program. The second phase is also known as the controlled motion phase and lasts for approximately 4 to 8 weeks. The goals of this phase are to increase the range of motion to up to 110 degrees or greater, promote full weight bearing, and improve strength of quadriceps and hamstrings, improve balance, neuromuscular control, and functional mobility. The goals of phase 3 or the minimum protection phase are to develop or maintain a maintenance program and educate the patient on importance of joint protection, make him an active ambulator in the community, and improve his cardiovascular or pulmonary endurance. The third phase starts from 8th week onwards. So phase 1 has certain interventions which can be summarized along with their rationale. First, to prevent vascular and pulmonary complications, ankle pumping exercises with leg elevation and leg elevation are primarily used, and deep breathing exercises are used to maintain lung compliance and reduce the risk for DVT or pulmonary embolism. Second is to promote or to control pain and swelling. Cryotherapy, compression therapy, and elevation is commonly used. Third, to minimize the flex inhibition or loss of knee and hip musculature, muscle setting exercises of quadriceps, hip extensors, abductors, and hamstrings are commonly given. Active assisted range of motion and active SLR in supine and prone can also be given, along with wall slides, mini squats and lunges. Next aim is to improve or maintain the strength of the contralateral extremity. The progressive resistance exercise of the non-operative extremity are particularly given. Fifth aim is to improve the trunk stability and balance, and for this trunk stabilization exercises, balance activities and setting, weight shifting and bilateral stance are given. Next aim is to improve the knee range of motion, and for this various close chain exercises and patellar glides are given. Such patellar glides can be given, interventions like heel slides, heel drags, agonist contraction, gravity assisted assisted knee extension by towel roll method can be given. Now, what are the criteria to progress to phase 2? There should be minimal swelling and pain. The incision should be well healed. The patient should be independent in all his basic ADL and ambulation, and his active range of motion should approach full or 0 degrees of knee extension and 90 degrees of knee flexion. Just like phase 1, we have aims and interventions along with their rationale. So first aim is to increase the strength and endurance of the hip and knee musculatures. So for this, interventions like multiple angle isometrics and low intensity dynamic resistance exercises can be given. To increase knee range of motion, low intensity self-stretching, stationary cycling and self-administered patellar glides can be given. Third, to improve standing balance and trunk stability, trunk stabilization exercises, proprioceptive and balance training, that is, can be incorporated. For example, tandem standing. Next aim is to improve the functional mobility. For this, symmetrical heel-toe walking, ascending and descending stairs can be given. And 4 is to improve the cardiopulmonary endurance, and for this, aerobic conditioning on stationary cycling, upper body ergometer, etc. can be used. So following are the criteria to progress to phase 3. So active range of motion is supposed to be 110 degrees of knee flexion, and hamstrings and quadriceps muscle strength has to be at least 70% of the non-involved side, and there has to be minimal or no pain during exercises. And phase 3 approximately begins at 8 to 12 weeks and focuses specifically on task-specific strengthening exercises, which again will vary from patient to patient, proprioceptive and balance training exercises, and and then you have advanced functional training, which will again depend on the patient's functional demands, and we have to continue cardiopulmonary conditioning program. Following are the exercise precautions that have to be kept in mind post TKR surgery. Firstly, the surgical incision has to be monitored throughout the exercise period. You have to look for signs of excessive tension on the wound. Joint mobilization techniques to improve range may or may not be appropriate for every patient, so it has to be considered. And SLRs are postponed and sidelined for 2 weeks after cemented arthroplasty and for 4 to 8 weeks after cementless arthroplasty to minimize the varus and valgus stresses. And the weight-bearing considerations according to the stages have to be kept in mind always. And following are the techniques to demonstrate to improve knee extension. These are the techniques to improve knee flexion range, and these are my references. Thank you. Hope this video was helpful. Hello everyone. This video is aimed at giving a brief overview of the Physiotherapy Rehabilitation Protocol used in MCA Infarct, also known as stroke. So what is stroke? Stroke is defined as a sudden neurological deficit caused by a focal vascular lesion in the brain. The brain is supplied by the circle of Willis, of which the middle cerebral artery primarily supplies the superolateral surface of the cerebrum. Following is the diagram of the circle of Willis. So as we know, the middle cerebral artery and its various branches primarily supply the superolateral surface of the cerebral hemispheres. It includes areas such as the primary motor cortex, the internal capsule, Broca's area, Wernicke's area on the dominant hemisphere, the parietal lobe, and also the somatosensory area. So, if there is an MCA infarct, what could be the possible functional and structural impairments? Let's understand this with the help of the following table. So this table depicts the structures involved and the possible neurological deficit that can be caused. For example, the involvement of the primary motor area and the descending fibers to corona radiata cause contralateral paralysis or paresis that primarily involve the upper extremity and the face. The lower extremity is more or less spared. Similarly, Broca's motor area involvement on the dominant hemisphere can give rise to Broca's aphasia. Similarly, you have the involvement of the optic radiation of the internal capsule, which can give rise to contralateral homonymous hemianopia. So maths to remember. We need a mnemonic, right? Yes. So this is the mnemonic to remember the common MCA infarct signs and symptoms, that is, changes. CHANG. Simple, isn't it? So what is the management of stroke? Let's understand this, that it is a teamwork of medical, pharmacological, surgical, and rehabilitation specialists. Following is the overview of the medical management of stroke, with primary aims of improving cerebral perfusion, circulation, oxygenation, blood pressure, controlling arrhythmias, and maintaining fluid levels. So what are the aims of rehabilitation? So the interventions included herein are of three types. 1. Preventative, 2. Compensatory, and 3. Restorative. So the rehabilitation protocol used in the acute stage is as follows. First, positioning, then counseling, education to family and caregivers, chest physiotherapy, weight-bearing activities, mobilization and stretching, oropharyngeal retraining, and sensory re-education. So first is positioning, which has the following uses. Bedsore prevention, to prevent and control development of synergy patterns and prevent contractures and deformities. So the blue side depicts the affected or the hemiplegic side, and this is the way it is usually positioned. The second aim is to maintain the existing joint flexibility and integrity, which may be compromised because of the flaccidity or cerebral shock phase. Interventions include soft tissue mobilization, stretching, passive range of motion exercises which will be followed by active range of motion exercises, active assisted range of motion exercises, and ARM on the ineffective side. Next, to stimulate or improve tone in the muscles, weight-bearing activities are incorporated to basically maintain calcium homeostasis in bones and increase tactile feedback, which will cause a subsequent spilling of stimulus and formation of newer pathways. Examples include bridging, weight-bearing through affected arm and feet, and so on. So this picture depicts the bridging activity. Next is a very important component, that is the arrangement of the room for the hemiplegic patient. To combat sensory deprivation, all the stimulation is given on this affected side, such as the television, the phone, and other parts of the hemiplegics room are accordingly arranged. The next part or the protocol includes chest physiotherapy, which primarily aims to maintain lung compliance and prevent the chances of secretion accumulation. Inspiratory breathing exercises, postural drainage, and nebulization may be used for the same. Dysphagia is a commonly encountered problem after stroke. Thus, oropharyngeal retraining becomes very important. Techniques of Rude's approach, such as icing, stimulating lip closure, and stoking can be used. Psychological counseling deals with motivating the depressed patient and his relatives in giving appropriate referrals so that the patient is benefited. The subacute stage focuses on improving the functional status, bedside mobility skills, normalizing tone, facial muscle retraining, and improving and maintaining joint flexibility, range of motion, movement control and quality, also maintaining the muscle integrity. So following are the activities which are used to achieve the same. This component makes the patient as independent as possible in his activities of daily living, that is, training for transfers. Next, various equipment can be used for training control and improving the quality of movement, such as vestibular ball, stimulation, and so on. The next part of the protocol is the chronic stage, wherein the main aims are to improve postural control, balance, proprioception, gait, cardiovascular endurance, and train the patient for specific activities via motor relearning program and improve his overall coordination. So this is a brief way of depicting how balance can be trained using the vestibular ball. Various techniques include using the vestibular ball or tilts board exercises, giving perturbations in various static and dynamic postures, and repeating the tasks for training for balance. The next component that needs to be trained is gait, and this can be achieved by the means of robotic assisted gait trainers, or mechanically by giving the patient appropriate assistive devices and giving him appropriate feedback so as to improve each and every component of the gait cycle. Lastly, we have to train for cardiovascular endurance, which can be achieved by treadmill walking, stationary cycling, and so on. For coordination training, various coordination tests itself can be used. Examples are fingernails test, heel and shin test, and so on. And task-specific or goal-specific training will depend on the functional needs of the patient, and they widely differ from patient to patient. Thus, this was a brief overview of the rehabilitation protocol commonly followed. Thank you, and these are my references. Hope the video was helpful.